Good afternoon. Welcome, everyone, as I take my mask and glasses off at the same time. My name is Carol Durham, and I'm faculty at the University of North Carolina at Chapel Hill, and I have the distinct honor of introducing Suzan Kardone Edgren. Susie and I have been colleagues for over a decade plus, and it has been such a pleasure to work with her on so many things, simulation and beyond. So I'm just going to highlight a few things about her, but I'm just saying, we were so involved and engrossed in conversations that we're like, oh goodness, it's time to start. Isn't that really one of the best things about conferences, that you can sit down and start talking to people? But Susie is internationally known for being a speaker and an educational researcher, and that's really important. You might recognize her name from the landmark National Council study about simulation that really transformed the way we really thought about simulation, and the Sentinel study is still crucial to our work in simulation, that 50% of traditional clinical could be substituted with simulation. She's also has been the editor-in-chief for clinical simulation and nursing for over 10 years, and is currently the editor-in-chief of 2 new interactive online review guides for those seeking certification in the Society for Simulation in Healthcare. She's been the recipient of many awards, including lectureships, and she has served as chair of the research committee in ANEF, and she's a fellow in several societies, Society of Simulation in Healthcare, and the Academy of Nursing Education, and the American Academy of Nursing. She's the current president of ANEF, and that's near and dear to many of our hearts in that organization. And she's also a senior fellow at the Center for Medical Simulation in Boston, associate professor at MGH Institute of Health Professionals also in Boston. We are so privileged to have her come and talk to us today, because as we know, there is a tight link between simulations potential and patient safety, and has been from the envision that Cronenwett and team had to include pedagogy of simulation in their work. So let's give a round of applause to welcome Susie to QSEN.
Thank you. It's just, you work in simulation, you say, can I figure out how to run the slides? So I'm going to be talking about something that happened completely serendipitously, and it's become, we didn't know we were going to find what we found. So the real title in my mind is Wandering in Wonderland, Implications of Recent Research about Clinical Education in U.S. Pre-licensure Nursing Programs. And really, let me get all this stuff done. No COI. We're going to talk about the findings of these studies, qualitative and quantitative, that we did about traditional clinical education, and we're going to consider implications of these findings in light of QSEN and what you all do, and potential and the new AACN essentials. So during COVID, we all know everything was locked down. One of my buddies, Kim Layton, is over in Qatar, and we discovered WhatsApp, and you can talk for free for hours and hours and hours and hours on WhatsApp. So we solved the problems of the world. And we knew that there was no clinical going on during this time in most places around the United States, or very limited clinical. And we said, well, we've always heard, everybody always says this, it's so important, it's so important. And we said, why is it so important? What do we say we're getting out of this? What are the outcomes of traditional clinical? And so we said, oh, that's a really good idea. And we could do this from wherever we are, and let's just give that a whirl. And we had background, and we had articles and little quotes that we'd saved for years that we put into a lot of, particularly my work, because I've been sniping at traditional clinical education for quite a while. And so one of them is, this eminence-based belief has been held for over 50 years. And relied on expert opinion rather than a careful assessment of the research evidence to the contrary. And to me, this was just like a shot across the bow. So show us, what are we getting out of this? So I thought, why don't we just do that? Let's just see. And it's not that we are not such original thinkers, because David Gaba, who is basically, for simulation, the father of simulation as we know it, in the Society for Simulation in Healthcare, he said this: the current system of education, training, and maintenance of proficiency has never really been tested rigorously. And he was saying this about medicine and healthcare training in general. So he knew it too. So we said, let's just go ahead and do this. But we had 3 simulation people who we knew wanted to do this. So it was Kim, our friend Colette Foisy-Dahl, who's a Canadian, me, and we said, no one's going to believe us if we come up with bad results, because they're going to think we are so sim-specific, that we said we need to find a ringer, somebody who doesn't like sim and will do this work with us. And our friend, whose name is escaping me, Angie McNellis, said, I'll do it with you, I'll do it with you. So we had our person who was going to keep us honest in our research team. And so that is why Angie got sucked into this experience. And so we had to come up with the aim of our research, and it really was to examine the best evidence available upon which to base decisions regarding the use of traditional clinical experiences with pre-licensure nursing students. We defined clinical education, and we looked at the background, which really was clinical practice with real people has always remained the gold standard. We've all heard this, we've all been brainwashed into this. So if it's so awesome, you would think that people have published, what are we getting out of this? And so my friend Kim says, okay, we're going to do a systematic review, which none of us had ever done. And she said, okay, I will read the directions for the Joanna Briggs Institute. And so that's what she did. She read the directions, and we, because we didn't know what we were doing, we followed them step by step by step. We learned the Covidence software, which if you ever have to do any kind of review, that is the way to go. It is awesome. And we had a professional librarian help us do this work so that we missed no keywords, nothing. So we tried to make this as rigorous as we possibly could. And so we used the PRISMA review. We did a systematic review using PRISMA guidelines and the Joanna Briggs Institute methodology, which in the medical world, they have no idea what that is. We couldn't have gotten this published in any medical journals just because they don't know what this is. We had 43 search terms, not simulation, not skills laboratory. We searched 9 databases. The inclusion criteria, it was written in English, and we did no limitation on years. So if there was something from 1875, we were going to use it. Interestingly enough, we only found 118 full-text articles, which was a surprise. So then we started reading with our criteria sheets, and we got down to 6 that kind of almost, maybe if we squinted our eyes, kind of really approached what we were talking about, but none of them really did. So as we found this empty review, we didn't know what that was. Our librarian had to say, well, I can't believe you found this, but you have an empty review. And we said, okay, what is that? And they said, that's when, usually this happens when a topic is so new that there's nothing in print yet. I would not expect it of something like this because this is something that's been done forever. So she said, you have to think about the political implications of when you say there's nothing. We said, okay, well, we have these 6 articles that we could kind of say why we could maybe almost talk about them and talk about what the problems were with these articles that would make them really not fit. And so we really do have an empty review. So that's what we decided to do, to keep ourselves honest and to politically smooth the hurt that we were going to cause people. So what we found was that one had an investigator design tool, which is not a crime, but they did no reliability, no validity, and no inter-rater reliability report on what they had done. Somebody reported using a half-split method, and we know that that's really a split-half reliability. And we said, how much do we want to believe this if they don't know what they're talking about there? So we kept that one. We had another one that said they gave no indication of how clinical teaching associates were trained or the faculty educators, and I think we could probably all say that. Who actually can talk about how they train their educators? Raise their hands. Usually somebody could say something, like we kind of orient them. Okay, I see 1, 2, 2.5. Okay, there we go. Okay, there was no description of a clinical day, not how many hours, not what's expected, what is supposed to happen, how it was conducted, who was there, et cetera, no number of students, et cetera. The case studies that were used in the post-conference did not match anything that was happening in the clinical that was going on. That was something that was interesting. The content validity of a tool was not understood by the people who were writing about it. And this always makes me wonder, as an editor of a journal, how this got past the reviewers and the editor to be able to publish something that was not this well done. And then the combined students and the instructor mean scores and came up with a gain score on one. And we said, this is really creative, but no, this is not what you would do. So those are the 6 articles that we came up with. And I'm wondering, I want you to do a think, pair, share for just a second and talk about what do you think about that. So I'm going to give you 2 minutes. Talk with a buddy, make a friend, and talk about what does this mean to you. Five more seconds. Okay, let's come back together. Does anybody have anything they want to share? Did you hear any really deep thoughts, anything that you think everybody in the room needs to hear? Don't be shy, we're among friends. Say again? Did anybody hear anything in their little groups that they think we should all hear? Don't be shy if you came up with a brilliant thought. We all want to hear it. Okay, so it goes back to when nurses were free labor for the hospitals, and it all goes back to their own program. Could be. Well, that's kind of what we thought. And we sat around and we thought some more, and we said, this is so interesting, because we knew about the research that was out there that said that, we're not doing that well. There's this gap between what the practice wants and what academia thinks they're producing and these kinds of things. And we said, okay, so we see how this might be, because we don't seem to be even publishing our own findings. And if you had something that you thought was absolutely wonderful, wouldn't you be publishing those findings? So we said, if they're out there, people haven't published them, please do. If there's the secret diamond here in the room, please handle that for us, because we'd all like to know what you're doing. So we sat around and talked some more, and we said, just like what Deming said, every system is perfectly designed to get the results that it gets. And as we thought about this, we said, let's think about this. And let's think back to all the things we read in these 116 articles. And we said, sometimes it seemed like they were talking about qualitative outcomes of clinical. Maybe somebody wrote something about qualitative outcomes of their clinical programs within their schools of nursing. So we said, let's use the same, get the group back together, get the band back on the road, and put on a show. And we're going to go ahead and we're going to do a qualitative analysis. So our researcher went out there, our librarian, and pulled the articles that were available, and away we went. This time we found 109 full-text articles on qualitative outcomes. 26 articles met the review criteria, And we got down to 6 articles. And we used the Joanna Briggs Institute qualitative data extraction tool yet again. And once again, we found that nobody reported about an entire program of clinical. One place talked about, and this is, I know that we have done this in our own School of Nursing because I used to take students to Mexico to study the Mexican healthcare system and the culture, et cetera. So we published on those findings because that was a clinical outcome. So somebody else has done that, mostly from Australia, because they send students into Vietnam and into Thailand, into Japan, into places like that to study different cultures and different healthcare systems. But it was like a one-off. They did outcomes of nurse-run clinics. They did outcomes of clinical on the night shift, again, one school, one time. Transition to professional identity, again, one school talking about this one piece of all of the clinical outcomes that you might have. Practicing as a clinical dyad, so looking at 2 people taking care of patients and things like this. And development of caring skills, which came out of China, which I thought was fascinating. Based on the news that's there today where, well, I'm not going to talk about it because it's too awful. So as we sat there and we thought some more across the miles, we said, you can pretty much do whatever you want if you're doing clinical, because if you don't know where you're going, any road will do. And since we have not had any real planned outcomes, apparently, within our programs, and we could make a case for why that might be. You're at the mercy of what clinical sites you can get, what clinical faculty you can get. There are times when, as an educator myself, I would have walked up and down the freeway with a board sign on it that said, if you have a pulse, you have a BSN, and you have a valid license, we'd like you to come teach at my school. And we've all been there, so we know what that is like. And that's a lot of times who we get. So we want to think about that, and how are we preparing people to teach in clinical, and what do we expect them to get out of it? And I think we haven't really thought about it. So these are the 2 articles that are out there, and one of the questions that we had was that, is this going to be hard to publish? Because we're telling people basically, your baby's really ugly. And so, indeed, the first place we sent this, it was a desk reject by the editor, who said, we're not interested in publishing this. And we said, okay, so that is going to happen. So we sent it to the next place, which in this case was Journal of Nursing Education, and they snapped it up. So then we went to our third one, our second one we submitted to Nurse Educator, and they snapped it up. But we got an interesting email from, it could be Georgia Baptist College of Nursing, Mercer University. Dear Dr. Layton, I'm a meta-analyst and wanted to express how impressed I am with your empty review of clinical nursing education. It's a testament to the power of a well-conducted review to bring huge lacks or flaws to the attention of the research community. My doctoral students often come up with erroneous empty reviews because of inadequate search strategies. But your review was conducted with great methodological care. It's the first empty review I've seen published. And what does that tell you? Congratulations. I even already have at least one PhD student, the one who brought me this review, considering doing a dissertation following your recommendations. I sent this to a bunch of colleagues in nursing and to some of my meta-analyses colleagues. It's fascinating. I've been describing it as the emperor's new clothes of pre-licensure nursing clinical education. Interesting. I bet you had many struggles trying to get this published. So I wanted to offer some positive words of support and appreciation from one systematic reviewer to another. This is very important and impactful work. Thank you for your hard work. It's not hard if you have a professional librarian. And there's COVID to keep you at home and you can't do much of anything else. I just want to say that. So we were lucky and we had the time to do this work. But once again, I have to come back to every system is perfectly designed to get the results that it gets. And so if we don't have a map for where we want and what we want our students to learn out of clinical education, we can kind of make it up as we go along. And I think QSEN is trying to help with that. And I think this marrying with this AACN Essentials may help with that. But I'm not completely convinced at this time. It turns out that one of our authors that I just love is in the audience here. This paper was devastating when it came out in 2015. Kavanaugh and Sharpnack, Kavanaugh and Shweta. They did it in 2015, and they said at the Cleveland Clinic, they used the PBDS. Who does not know what PBDS is? Please raise your hand, don't be shy. It is a really expensive, very well validated series of vignettes, videos, that new grads watch, and then they write down 5 things. Is this an emergency? What would you do? What's going on with the patient? And 2 other things, it doesn't matter. Point is, it's very predictive of how much orientation they're gonna need to get functioning as a nurse. I was in Dallas-Fort Worth area when they started using this as to review all of the hospitals in the Dallas-Fort Worth area adopted PBDS. And if you did your first round, you got your 3 months of orientation based on what you did in that course with your preceptors. You took PBDS again at 3 months. And if you did not pass that time, you were not gonna work in any of the hospitals in the Dallas-Fort Worth area in the time that they were using that from that time forward. And the reason for that was, Dorothy Del Bueno said, you are one of the consistently inconsistent. And we all know what that means. On any given day, you have the student who may or may not show up mentally to clinical. They're always the ones that are riding the ragged edge, but somehow they pull it out and they pass at the last minute every semester. And we all know when we see them walk across the stage, ooh, please don't let me wake up on the gurney and look up and see that face. Oh, please, oh, please. So they published that great article, Kavanaugh, help me with it, Kavanaugh and Sweta in 2017. The next one was in 2021, Kavanaugh and Sharpnack, and Kavanaugh's sitting right there on the stripy thing. You should go, yeah, she's awesome. She's awesome. She brings us the news that we need to hear, and that in 2020, the PBDS scores had dropped from 23% in 2015 to 9%. And then in late 2021, it was down to 7%. That's pretty bad. And so the need is recognized. We know that we're not doing well with what we're getting out of clinical. I'm gonna give you 2 minutes to chat. What about this, and what are your initial thoughts? Have you heard this information? And if you want to go over and give her a hug, go over and do that. You've got 2 minutes to talk about this. Okay, you've got 5 seconds. And we're coming back together. Does anybody have anything that they heard at their table or with their friends that they need to share with everybody? What are your thoughts? Oh, it's not projecting. Could you please project the slide? Nope, 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 nope. We want to go. Nope, nope, nope. I'm trying to go backwards. There. Okay. Right, so it just got worse. And they weren't in clinical from 2000 to 2000. Yeah, that's right. That's right. And Joan says it's even a little worse now because they've been following it. So this is reality. This is where we are today. And so how are we dealing with this? Let's think about this. Remember that we were really hooked on clinical hours, and depending on the state that you were in during the pandemic, we were allowed to use simulation or not. Certain hours had to be made up in certain ways or not. So we had a natural experiment going on in different places around the United States, or actually around the world, as this was happening. But what we really had to start facing was there is no evidence linking any specific number of hours to improve student outcomes. And we know that in the National Council study, the range in the United States in 2011, 2010, when we were planning the study, was somewhere between 250 up to about 1,800. And everybody graduated and everybody took NCLEX and people passed or they didn't. So that was then. This continues now. There's nothing magic about the hours. But we've always kind of held on to the fact that we think that that's really, really important. Then we have the study that, again, how do these things get published? This is in 2018, and the title is No Evidence to Support the Number of Clinical Hours Necessary for Nursing Competency in Pediatrics. So Ann Bowling and group, gosh, I hope you're in the room. You can tell us about what this was like for you and what it's like me standing up here talking about your study. They said, we have no evidence to show this, but we have a group of experts who got together, and we have decided that you need between 61 and 80 hours of pediatric experience to be able to learn all of the things that the pediatric nursing group wants you to know as coming out of school, as a new grad. So once again, it was just we believe, expert opinion. There was no research, and yet we spend time talking about evidence-based practice with our own students. So again, I have to say, why do we keep doing this? And now, all during this time and post-COVID, a lot of us are longing for the days when we can go back to the way things were before. And what we really want to say is that the 20th century ideas continue to pervade the 21st century. We require PD and OB content, and we know that you can't find clinical sites. So I could say, I don't mind PD and OB content, but I don't know why we have to do clinical for that. Those are two specialties. And it was by happenstance, post-World War II and during the baby boom, that the two clinical specialties of OB and pediatrics made a lot of sense because people were having lots of kids. When you can't find clinical sites, but I've got more and more older patients available, why don't we have geriatrics as a specialty? We know that all the nurses that really held on to those great surgical positions in the hospitals are getting ready to retire. Why don't we have surgery as a specialty? Why have we chosen, and we keep holding on to pediatrics and OB? I don't understand this. In a lot of places, we have some geriatric content. Other places, it's woven into everything that we do. We need to be thinking about this. We still continue to talk about hospitals and acute care focus. And someone reminded me that I was just on a panel at ATI with a guy who was representing the National Council of State Boards of Nursing. We said, you basically, whether you want to believe it or not, you drive what we do, because we all want our students to pass the test that allows them to practice. And you don't really have a lot of community health or other kinds of things in the content. He says, well, actually we do. We just haven't necessarily framed it that way. I said, come on. And so we do need to let them know that we're really looking for other things because they know they drive what we do. although they say that that test is not hospital specific, and I think that a lot of us would tell you that we think it is. The other thing is that rehab and chronicity are optional also, and yet we know that there's more and more of that needed now as people get old, as are living older and to older and older ages. Death and dying and cultural content is often optional. I will tell you that for a while they put cultural content into the NCLEX. It was in there for about 3 or 4 years, and then they took it out. Why did they do that? You should be asking your state boards of nursing, especially as we have so many people entering the country from everywhere at this point in time. And death and dying culture, there was a recent research study that said 49% of all students during their clinical rotations while in school experience a death. And they are almost never, and 49% of those students said, and we were never debriefed about the death experience that we had in our clinical rotations. We never talked about it at all. And I contend that that is part of, for many of us, the hidden curriculum of nursing. Our books a lot of times don't really have a chapter on death, hospice, dying care, things like that. It's just like it's never gonna happen. What are we doing? Why do we do these kinds of things? I don't understand. And then the baby boom is busted, where we have old people and we don't have a lot of new births. As a matter of fact, I was just talking with somebody. The birth rate went up for the first time since 2015, this last year, by 1.5% in the United States. So if you look at the demographic drawings of what we look like, it's old down to nothing. And it's this upside down pyramid. You've got to think about that. And this is why we can't find clinical sites. So we need to be thinking about this and then making a difference. One of the things I know that we really pride is that knowledge is so easy to teach. But it's necessary, but it is not sufficient for clinical practice. And I had several friends that were the A students in the class. I was always the B student in the class. They all ended, no offense to anybody in utilization review, but when they couldn't find A, B, C, D tattooed on the person's chest, they could not cope with nursing on a floor. They needed to go someplace where they had good control over what was going on and they'd be able to see what they wanted to see. So I want you to think about that. We really are good at testing knowledge, but can they apply it? And I want to say we need to think about those kinds of things. Post-pandemic, if you've read all the extra things that every specialty wants you to include with everything else that we already have to teach, it includes disaster nursing, epidemiology, how to do contact tracing, enhanced community health, and add social determinants of health, and DEI, and. And I say, so if we want to keep them in school for 6 years, we can probably do that. So we're going to have to make some decisions based on what we're trying to produce. We need some clearly defined performance expectations based on observable behavior, not coloring in a dot on a test. Medicine has been doing entrustable professional activities since 2014. They are ahead of us as far as this goes. And they have an advantage in that I think it's one curriculum pretty much around the United States. Everybody takes a certain classes at certain times so they could do that hard work. We have the cross to bear that we don't, and every school kind of does things a little differently. I know in the National Council study, the only class where we could run all the data at one time was the foundations class, because after that, in the 10 schools that were in the study, everybody was doing something else till the very end. So none of the data could be collated except by individual school, not aggregated all together until the end of the study. So we know that entrustable professional activities are the way to go, and we need to sit down and talk about this as a group. I started working with a group in probably 5 years ago about this, and it's like trying to grab water. It's almost impossible to get a group of people to agree on these kinds of things. And this is something as simple as walk in a room, basically do a basic assessment of a patient and get a set of vital signs. I'd be really happy if we could do that. And we know that we check them off in foundations for that, but then they use the doc on a stick the rest of the time they're in school. So if you should check them off on checking a blood pressure as they're getting ready to go out of school, a lot of students can't do it. They could do it once, but they haven't had to do it since. So we have to think about, what do we want people to be able to do? And that should be the core, not the ceiling. And I hear that you had somebody talk about this yesterday. Well, you can see that a lot of people are thinking about this. I think it's really, really important. Entrustable professional activities for entering residency for physicians look something like this. Documenting a clinical encounter in the patient record. Gosh, wouldn't that be wonderful if we all had electronic health records we could actually try out? A lot of us can't afford to buy those. Provide an oral report that is suitable for the next shift to take over from a clinical encounter. I think a lot of us could probably do that. Prioritize the diagnoses and needs of a clinical patient. I think that'd be wonderful if we could really do those kinds of things. Perform a basic history upon admission and perform the physical assessment that should be done with that patient as they enter onto the floor. I don't think those are hard things to ask, and a lot of these can be tested through simulation. This is one of the new next-gen test questions, and while I saw these the first time at a conference as a preview kind of thing, I started laughing because I said, I don't know if I can do this. I don't know if a lot of the faculty can answer these questions. And we're going to now be tasked with writing these questions. And we all know friends, and if it's not us, who say, I wrote my test last night. You can't write this test last night. This is going to take you, they said these kind of questions take 6 to 8 hours with a group of 4. So this is what this takes to do. And once again, just because I can answer the question does not mean I can nurse my way out of a paper bag. I need to be able to go in and demonstrate that I know what to do with this information on the patient in the bed, or in the office, or in the school. And so once again, we tend to focus on the easy to measure, knows and knows how. The shows how, which is hands-on, and does are harder to measure. It's going to cost more money. It's usually all hands on deck. And wouldn't we all learn a lot if we did what medicine did and they all pony up on those days when they do OSCEs? Nobody can take vacation. Everybody has to show up, and we're all going to put people through these stations, and we're going to see what we know. They've norm referenced everybody so that we all know what we're going to do. They actually frame of reference testing. We know what the gold standard is, and we know what we want our people to do. So I'm advocating for something like this, and I think it should be a demonstration project in each state. You only need a few schools as demonstration, and then just a few people, so a stratified random sample, just to get a benchmark on where we are so that we don't have plausible deniability about how great we are. The other thing we need to talk about is what is the question of competence. Competence with CPR, we knew you could test out in CPR, walk across the hallway, and you could test on CPR again and fail a minute after you just did the test with the person watching, because they really can't tell with their naked eyes if you know what you're doing or not. So this is something we need to consider. And competent, I checked you off in junior 1. Why can't you do this now at senior 1? I don't understand why you can't remember this. Because we know from cognitive science now that people don't learn that way and they don't remember that way, especially our young students, because they are dating, they're doing whatever they're doing, growing up at that young age, and we're trying to fill them like a fire hose full of stuff. And so we are asking very young people to do very difficult things really, really early in life. And I don't think we've ever really managed this question of competence. How are we defining this, and for how long, and what does it mean? We need to move from a performance-based mindset, which is I got the A on the test. The really great student in simulation will say, I guess the A I got on the test last week doesn't really make a difference. And that's somebody who's had the aha moment of what simulation can do for you, because they're saying, I know this, but I don't know that now's the time I'm supposed to apply this. And so in a lot of our simulations, we sit around and say, at the break, we say, all that lecture last week and all those notes you took, this is what this looks like in the clinical environment. So if you want to pull those notes now and walk in with you while we do this again, you can see those words look like this. This might be a technique you want to try, just so that the students start making that connection. And we want to help them develop a learner mindset, not a performance mindset, which is I got an A, so nothing else matters. And somebody said, I need to know it in junior one, I need to know it in senior one, I need to know it when I get out of school. This is really, we're teaching them their craft. This is not survive school and then I'll learn what I'm supposed to learn in the real world. So that sounds like a real paradigm shift to me. And a lot of us in this room are willing to do this, but we have to go back into our own real worlds with people who don't do simulation and don't come to the QSEN conferences and don't necessarily embrace the AACN essentials. I've worked in a place before when QSEN first came out, and I was sitting with I'm going to sound ageist, the ancient person who was in charge of the curriculum committee, and this is years ago. She's still there, just saying. And she said, oh, we already do all these. And I said, really? How do we know that? And she said, well, this one, we do this way. And here, we do this way. And so there's a lot of that going on, is that, well, we already addressed that. We already addressed that. And perhaps you've seen some of that where you are. We have to have a real deep dive and really pay attention to what we're saying we're doing with what we're teaching and how we're going to be checking out these things in our clinicals and in our simulations. And so people will say, and I love this little thing, I'll just be quiet and let you read it. People say, we can't do this with simulation. We can't do benchmarking. We can't do all these things. And I'm going to say, yes, we can. They do it in Canada right now. And I was called by this group who's in British Columbia. They said, we got the contract to test all the foreign nurses that come into British Columbia. We're doing it with simulation. They're bombing out left and right. And somebody told us we should contact you and talk about what we're doing. And I said, do tell. I said, so what is it you're doing? And they said, well, we bring them in. We make sure the English is good enough to handle what we're going to do, and then we show them the mannequin, and then we put them through their paces. I said, so you're saying that you have people coming in from foreign countries who you're now putting through high-stakes scenarios, and they've never actually laid a stethoscope on a mannequin before. Well, no. And I said, well, okay, and how many people are passing? Well, nobody's passing. And I said, okay, well, I can offer you some tips. And we started a relationship then and helped them get better at getting better about doing this. And it became to work really well for them. So what they do now is they test you out of the country on your knowledge. And then when you fly in, they put you through your paces in these scenarios. And they used to have a video up of one of the scenarios. And the person is sitting up at the side of the bed. It was a man in his gown, so it's a standardized patient. And he keeps saying, oh, I just don't know if I can go on. And obviously he's depressed. And the nurse is so busy getting him his slippers and his robe so that he can ambulate that she's not listening to a word he's saying. And they said, and do you think this person passed, yes or no? The answer was no, because she was not doing holistic care, which was listening to the patient. And I have to wonder, if you put your own students through high-stakes assessments, would you have that person? They're so focused on tasks that they can't see the patient for all the tasks they have to do. So think about that as you think about this. But this company, and I went on their website recently, and I think it's been sold to a larger conglomerate, but they're still doing this work. So it's the Nursing Community Assessment Service. It's in Vancouver, I want to say. And this is what they do. So it's been going on, it's been doing it a long time, and I don't know if it's spread to other places in Canada, but there is a group that's doing this now. Seems to be working very well. So if we had to start with the end in mind, I think we'd all agree that what we want is a safe practitioner. But how do we get there? And I think a lot of us have been raised to be process-oriented. I teach this course. And then we teach this course. We have not been thinking about what is the end product we're trying to produce. And one of the best books that nursing education usually never touches is this book by Wiggins and McTeague called Understanding by Design. And you use a backwards design technique. You begin with the end in mind, and then you work backwards. If you had to do that, what would you not teach, and what would you teach? So I want you to think about that. I would love for you to find this book, And I'd love for you to read it. And when I first read it as a simulationist, about every other page I had writing all over it, this applies to simulation, this applies to simulation. It applies to clinical, it applies to clinical. But nursing education, for some reason, does anybody use this in their education classes? Anybody? 1, 2. It's the best book you've never heard of, I'm just telling you. So the question then becomes, what can't you learn in the online environment or in the clinical environment, in the simulation environment? And the things that were listed in this Macy report in 2018 basically said professional identity, learning to communicate with the patient, the organizational culture and practices, and Susieism for that would be, who's got my back, who's gonna stab me in the back. We all know different organizations have different cultures, and different units have different cultures on them. And really, the report finally said you can really learn almost anything if you design the learning well. And I don't think that we've had our feet held to the fire to really think about that for a very long time. So I'm going to challenge you to think about that today. I have intriguing research questions here. I'm just going to be quiet and let you read those. And implications for educators. Mounting evidence is that clinical practice hasn't changed. We want to go back to the way things were, and yet we know we can't. Are educators engaged in clinical educational outcomes research but not reporting it? If somebody is, please report what you're doing that's really good, because there's a dearth published at this time that we can find in the literature. There is a lack of standardization or valid and reliable measures for clinical outcomes. I don't know that they exist. That's a huge gap in the literature. And the AACN essentials are competency-based program outcomes. We looked at clinical outcomes with a group of us, and you can drive a Mack truck through them. Take a look at those, and if you can operationalize them and get that out and published in the literature, that would be very helpful to everybody. And we know that the difficulty lies not so much in developing new ideas as in escaping from the old ones. And in my world, I know that there are people who are going to have to die or retire before things are going to change. I bet you know some of those people too. And some of them are on our boards of nursing. Some of them are leaders of our organizations. And one of my goals is always to be not one of those people that they say, oh my God, when is she going to quit? She keeps us going with all the same old stuff over and over and over again. So what I try to think about is this. This is a picture from like 1897 called The Fount of Life. Very modern picture for something that is that old. We can all be this, especially as we look at this opportunity that we have with the QSEN competencies, the new AACN essentials, and simulation as we move into the future. Any discussion? I have a few minutes for questions. Have I stunned you all into silence? Yes.
Thank you, Susie, for a very thought-provoking presentation. And I join you in thinking about that we have brought forth a clinical education system that is not a match for the 21st century. And some have said if you're educating nurses in the way that you were educating, you're educating for a healthcare system that no longer exists. So have you thought about, and do you have a vision for what kinds of change could we begin to do? Of course, there's simulation, you've addressed that, but what are some other ways that we could begin to bring clinical education into the 21st century to begin to address what the current healthcare system is like?
I will tell you that Paula Gubrud-Howe from Oregon Health Sciences University, years ago, so in the 90s, they had a designation, they had a grant for it. Of course, there was a grant for it. And anybody who was going to teach clinical in the state had to go through an online prep. and they had to pass a little test to get this. And then they got a special stipend because they were teaching clinical. And they had had some training in how to teach clinical. And there was a little initials after your name that you got because you had this designation. And that lasted for the life of the grant, and then it went away. But it was a great idea. And I think that preparing people for what we think we want out of the clinical experience, when I'm hiring people a week after clinical started because I need a warm body, usually they don't get a really great orientation, and they're going to do what they're used to seeing done and what they did. So I think we need to pay more attention to what we think we want what we want out of this, and how we're going to prepare people to help us get what we want out of it is one thing I would do. What are you thinking? Great question, and so Australia and a couple other places use like the 2,000-hour model, and you're either an educator that you teach in the classroom, and then preceptors are basically all over the place, and you get assigned a preceptor, maybe not even in Australia, you may go to another country, and you want to think about that because with 2,000 hours of clinical, you're probably going to learn something no matter what. When you have 1,800 hours or you have 600 hours, you're only going to get so much out of it. So the question is, are they successful because of that model or despite that model, just because of the number of hours that they put in getting familiar with the clinical environment and such? I can't tell you, I don't know. But no research really has been done on that. So I have more questions than answers. And you guys are the ones who are working in this area now. Yes, ma'am.
So thank you. This is just, I sat here nodding my head going, yes, yes, yes. So one comment I want to make is that my group is really interested. I'm from California State University in San Marcos, and I work with some colleagues, and we just presented here today a study we did on what we are doing to prepare clinical faculty, because that's a stumbling block that we need to overcome. So we've got some ideas about that. So that's one thing. But my question to you is that, can you tell us what we can do besides going to our legislators, which is what we did in California during the pandemic, to convince our boards of registered nursing that they need to come to a QSEN conference? And I don't mean that facetiously, but I'm just saying that our board is so controlling in what you're saying about pediatrics and OB, and they are prescriptive. And we literally, during the pandemic, we got very little relief, and we did band together the colleges of nursing and the universities of nursing, schools of nursing at universities, and we got emergency legislation to get us to go to 50% simulation because the regulators just couldn't do that. And so how do we bring them along on this journey? How do we help them understand where we need to go with nursing education so that we are really truly partners with our board and not just kind of at odds with them?
One of the things I would do is find out if you have any nurses who've been elected to your legislature. Senator, I don't know what they've gotten in California. We have our Senate and our congressional group for the state of Texas. And I will say, if you have a nurse that you could take with you or a physician that you could take with you to those kinds of things and say, if you want to be famous, if you want to really I can make you famous. This is the way I would go. I'm going to help you become famous, and I want you to really concentrate on these kinds of things. Let me educate you. Let our organizations educate you on this. Come with us to clinical for a day, see what we do in simulation, and let's compare the two and see how we can help move the legislature forward. That might work. Has anybody tried this?
to the board, and they got the simulation approved afterwards. So data speaks.
Data speaks, and so this is a person, so say your last name.
Oh, I'm not Kathleen. I just know
Yeah,
of
I know, but
Kathleen
just
McGinnis.
stand up, so you have the information, you know. Look
Oh,
at her,
goodness.
you want to go see her.
A lot of you know Kathleen because you're from Colorado, but Kathleen McGinnis is
Okay.
here in Colorado. I'm Pat Kirikides, but I just am lucky to know her.
Okay, great. So that is an approach, I think, that you have to be able to speak data to legislatures, and they need to get some experience in it too, I think. So I would try to find or a sympathetic congressional person. Yes?
So I think also we need to be inviting. Invite those folks to come like you described, because our North Carolina Board of Nursing is here. And so I think that's really important to invite people to come to know what we're doing.
I will say that I think, Carol, you and I were at a conference that Pam Jeffries held where she had members of the Maryland board, the Virginia board, and some other board in the audience, and then they did a panel. And people just asked them questions about simulation and clinical and things like this. And just being exposed to the people who do the work, I think helped educate them quite a bit. So that's another approach that could be taken. Yes, in the back.
I think that's one of the barriers. See, is that people don't know, educators don't know which tools to use, whether it is in simulation or in clinical, so that we can actually start collecting that data with standardized tools.
Gosh, there are so many reliable and valid tools now for simulation that it's amazing. And they're found on Kim Layton's website, which is a Google site. So you just put Kim Layton's evaluation tools into Google and it'll pop up. And the Anaxel website has a whole research track and a whole page after page after page of tools and articles that have used tools that are reliable and valid, or are developing the reliability and validity of different tools for simulation. If they work in simulation, which stands in proxy for clinical, they should work in clinical. To me, that's like shooting fish in a barrel kind of research. You try them here, and then you compare the results and see, do you get the same results? If not, why not? And if you do, well, really good. Something else here? Yes.
Yeah, hi there. Thank you so much. That was helpful. That was a great presentation. I'm curious about your thoughts on using the healthcare simulation standards of best practice that we have for standards within simulation, and the transfer, how that transfers into clinical practice for those roles in clinical practice.
Why didn't I think of that myself? I have one of those baby faces. So one of the things that would really help so many clinical educators would be to look at the healthcare standards of best practice, because if they work for simulation, they should work for clinical. And it talks about how to do a pre-briefing, how to observe, how to do a debriefing, and there are many different kinds of debriefing, but this is something you do with your kids, you do with your spouse, you do with whoever. It's a way to communicate and to help people learn. So it is a language that we don't learn usually in school. I've almost never seen this taught in clinical courses. So I think that's a great suggestion and a great place to start if you've got nothing else. And guys, my time is up. So I want to thank you for being attentive. And I'm talking to my tribe here. So.